Usually when you hear the words hospital and housing in the same sentence, it's because medical costs are making people choose between paying those bills or paying the rent, especially here in Massachusetts, where rental costs are the third highest anywhere in the country, with an average two-bedroom in Boston costing almost $2,400 a month. But now 3 local hospitals are looking to do something about that. Boston Medical Center, Boston Children's, and Brigham and Women's are teaming up for what they call an innovative, stable housing initiative. And step 1 is to give $1.5 million directly to families struggling with unstable housing, like those who are behind on rent and facing eviction. I'm joined now by 2 architects of the program, Dr. Thea James, the Associate Chief Medical Officer and Vice President of Mission at Boston Medical Center. She's also an emergency room physician and one of the architects of the program. Good to see you. Dr. Shari Nethersole is the Executive Director for Community Health at Boston Children's Hospital. Good to meet you. And Andres Del Castillo, a housing activist and organizer for City Life, one of the grantees. Good to see you, too.
Thank you.
The seed for this was planted at BMC, yes?
Yes.
What was the thinking?
Well, about 2 years ago, when we realized we had a determination of need obligation coming up, we were looking at what would be the most impactful way that we could use it. And as we looked across our patient population and the greatest challenges they face to stay stable and to have good health care outcomes, and for their health to remain stable, you know, housing and unstable housing was a clear front runner. And we also knew that it had no one had ever asked the state whether we could use determination of need obligation funds to address housing. And so we thought that we would ask them, and that's how it came about.
So as it percolated, what was the thinking as to how this would actually work? I mean, what were the mechanics you were contemplating?
Well, I think that when you think about the uses of those types of funds, you could look at it a couple of different ways. You can look at how you address people who have emergency needs right away. You can look at, well, how can we change the systems and the policies that affect how people maintain or achieve housing as another way of doing it, sort of upstream kinds of approaches as well.
Before I bring you into the conversation, was it hard convincing your colleagues of something that seems totally obvious to me, even though I don't do what you do? Was there some resistance saying, we're healthcare providers, we're not housing assistance advocates, we provide healthcare to people? Did you encounter any of that resistance at either of your places or no?
I mean, I think in general you have to actually explain this connection.
The connection, yeah.
So I think there was a little bit of that. But it's interesting. We have a community advisory board, and for the last, I'd say, 5 years, our community advisory board has been saying that housing is a challenge for them, and it's actually affecting health. And we also have programs where we address asthma and go into homes and do home visiting and recognize that housing affects kids' asthma. So it wasn't really hard to make that
I assume
case.
it's even an easier sell at BMC, because I'm assuming the percentage of patients who have housing problems is astronomical.
Exactly,
yes?
but I still say that the greatest challenge is getting people to shift their mindset, not about, not only about the impact that housing has and housing instability has on people remaining well and being stable, but also what you can do to actually impact that, shift your mindset about what's actually possible. And even though there's plenty of data that show that things like education attainment, income, and all those things affect your life expectancy and affect the status of your health, I don't think people can make the link and understand that when people have, when they have limited resources and they have to make a decision about whether or not they use those resources to feed their families, try to maintain some unstable housing to keep the lights on and the heat on, or using those limited resources to pay for a prescription or a copay or even transportation to a medical appointment, it's an easy decision for them. Health and healthcare will always rank secondary to surviving.
And everything else suffers.
Absolutely.
You know, Andres, what are you doing you're one of the grantees here. Explain what this is going to mean in real terms for people who are at risk of losing housing.
Well, we're very glad, we're very happy to have the opportunity in this grant to be able to do the work that we do on a larger capacity. One of the first things that we're doing with that money is bringing in additional legal services to the table, because we often find the difference between the outcome of a case in having representation to not is it's enormous.
You know, people might be facing eviction proceedings.
Right. We had a member this morning who had to be up in front of the judge by herself. She had to advocate for herself. She had to explain her case by herself. And I mean, she's been trained by us. We train her at the Wednesday night meetings, what her argument is, how she should make it. We practice, we rehearse. But, you know, although she had our support and was able to do that effectively, there are so many tenants who the idea of being in court is so anxious. It provides a mental block. They just can't find the space to be appropriate advocates for themselves in that moment. Especially in immigrant communities where the notion of being in court, particularly in the atmosphere that we're currently in, is such a triggering experience. And so we really find that providing counsel or having that support is critical.
And by the way, for people say, I was a tenant lawyer when I was a kid in legal services. People say, well, there's legal services. Yes, there is, but you know as well as anybody, grossly underfunded, and the need far exceeds what's there. Right. You know, one of the things I've read about in places like Hawaii, for example, is people who have accepted, who are in positions like yours, who buy what you are convinced of, have sought Medicaid waivers from the federal government, saying in addition to whatever money we have to take out of our own pockets, federal government dollars for low-income people to care for their health should also be able to be used for some of the things that you were talking about a minute ago, Doctor. Have we done that in Massachusetts? Is it being contemplated? Is it part of the game plan, or what?
I mean, there have been Medicaid waivers for things. I mean, coming up soon, we have something called flexible flex funds.
Which would allow you to do things like this?
Well, it will focus on housing, like pre-tenancy, tenancy,
oh,
also nutrition as well. So, and those type of things, you know, can help us to not only just like house a person, not just like put a person in a house, because it's more than that. They really need support services and maybe even build in off-ramps that lead to things like independence and stability.
You know, I want to pick up on something Dr. James said a minute ago, Dr. Nethersole. It doesn't, I mean, this program is brilliant, and I celebrate, and I hope everybody does. It's just the tip of the iceberg in terms of what makes a healthy program. You touch on some of the things. If the kid has an empty stomach or has inadequate food, or if somebody is abused at home. I mean, I can go down the list. Education, as you talk about, they don't have the support that they need. Is this what you hope is the beginning of a larger look at how to treat the health of a patient, not just in traditional ways, and hopefully it'll expand beyond this?
Oh, absolutely. And in some ways, it's not completely the beginning. We've talked about this issue of what are called social determinants of health, you know, whether that's housing or food insecurity or violence or transportation, that those are all things that ultimately affect your health. I think the challenge is thinking about health in that broader context. We also then have to think about how do we allocate our resources as a society and think about some of these things that are upstream determinants of health, particularly for children, because for children, you know, the immediate effects are not on their health are not necessarily seen. The effects are seen over a long period of time. And so it's really more thinking about how do we sort of reset our thinking and invest more in some of these upstream approaches that address the systems, that address whether funding that's supposed to be directed towards societal issues can be used in this way to help actually affect health outcomes.
You talk about legal assistance for people who are either facing eviction or some other horrible fate in court. Are there also direct rent grants in these situations?
Yes, absolutely. And the idea behind those is not to recreate the other assistance mechanisms that already exist, but to fill gaps where those mechanisms don't respond to certain issues. So there's RAFT, there's other programs that provide folks the opportunity to catch up on rent that they maybe have fallen behind on, but there's very limited opportunities we have a lot of mothers who are single parents or have kids with special needs, and they need to be at home for their care of their kid, for therapy or whatever it may be, and struggle to be able to commute at the appropriate time. And so, you know, different mechanisms that would allow parents and families to be able to access services, because we do find that a big limitation is being able to access the service itself.
One last thing for you. While I celebrate what the 3 hospitals are doing, why isn't every hospital in town part of this compact? Are they going to be, doctor, are they going to be?
Well,
Is 3 going to become 5 and 8? And
when this was set up, and credit to BMC as they started to think about this in a way that other hospitals could join on. There is a group of the Boston hospitals that's meeting on a regular basis to address social determinants of health, partly in the context of the fact that we're in this new accountable care organization structure
right.
that's really saying you need to think about these other factors. But even prior to that, there's really been, through the community health and community benefits divisions of each of the hospitals, a real emphasis on how do we think differently about social determinants of health. And you need to think about it both from the individual family or patient perspective as well as the big picture societal perspective, because the way you address those needs is very different in those two situations.
Congratulations, all of you. I think it's terrific. Pleasure to meet you. Thank you so much.
Pleasure so much.
And to meet you as well. And great to see you.
Thanks, Jim.
Thanks so much for your time.